was really educational. Like Dr. Jayam Kannan madam said, within 5 minutes perimortem, you have to deliver the baby. Otherwise, it is also a legal problem if you do not deliver that way with classical C-section. Thank you. Thank you. Over to you, Dr.
Thank you, ma'am.
Thank you, Jayam Kannan madam, for such an excellent elaborate talk. Dhanyavad so much.
There's
Thank
a
you, ma'am. Thank you,
role
ma'am.
of consent in perimortem cesarean section from the audience. Question on what is the role of consent in perimortem cesarean section? There's a
No need.
chat box.
No need to get a consent.
I will tell you, if you permit me, Manunmani, now there is no need of consent. That is what Dr. Pandya told us in NOGS, our workshop on obstetric emergencies. No need of consent for perimortem C-section. And if you do not do the C-section, and even if the baby is inside, you are answerable for legal question. So you have to anyway deliver, baby live or dead, you have to deliver.
Again, nowadays with everybody carrying cell phone, please understand everybody is filming you. The casualty, everyone is filming you, and they have the free access to put it everywhere. Please have that in our mind when we, when we talk also. You don't know which pocket is carrying any videos.
It's like a big boss house.
Yes, ma'am.
Thank you. Thank you, Chairperson.
Thank you, ma'am.
Thank you, madam, for that wonderful, your talk is so amazing, madam. It is so nice. And I thank the chairpersons for moderating this very nicely. And we are moving on to the second session, which is a session on maternal safety bundle for hemorrhage. Maternal safety bundle for hemorrhage. We have with us the chairpersons, Dr. Pungode Arul Prakash. She is my senior from Madurai Medical College. Madam is the president, Foxy of Thuthukudi Society. She's she has got a collector award for her family planning achievement, and she has a very special interest in Tamil. And she is the vice president of Thuthukudi IMA, and she has got the best women doctor award from IMA. And she has conducted many community awareness programs in the schools, colleges, and villages. Welcome, Dr. Pungode Arul Prakash, madam. And I have the great pleasure to introduce Dr. Jasmine Rajesh Tilak. She is from Tirunelveli Medical College, and she had a postgraduate done in Madurai Medical College. And she has her training in Simar Institute in the infertility training. And she has delivered the first IVF baby of Tuticorin. And she is the present secretary of the Thuthukudi Foxy Society. Welcome, Dr. Jasmine Rajesh.
Thank you, ma'am.
And I have a great pleasure in introducing my good, young, beautiful friend, Dr. Nirmala from Queen's Fertility Center in Tirunelveli. And she is the secretary of Foxy of Tirunelveli.
Past secretary.
Past secretary. No problem. Always a dynamic person is always the secretary of the society. Vice president of IMA Tirunelveli, secretary SPCA Tirunelveli. And she's the co-convener and Friends of Heritage Sites. Over to you, chairpersons, for this session. Sharing
Thank
your
you,
session and taking over the session.
Thank you, Zerami.
Thank you, ma'am. Thanks for a nice introduction. We are looking forward to hear from Dr. Varsha about this hemorrhagic bundle. So let me introduce Dr. Varsha again. She needs no introduction. She's a practicing gynecologist at Pushpa Fertility Center. We already done this, yes, ma'am. And you're the poster girl for anti-aging stem cell center. So over to you, Varsha, ma'am, for your talk.
Thank you. Thank you. Actually, this is my old CV. Saiti has put in, but it's okay. Next time I will ensure that the new one will be replaced. So should I do the slide share? Thank you so much, everybody, for attending this very prestigious webinar, and more than 200, and on YouTube also many have logged in. So I'm really happy that people are taking advantage of this webinar and for their practice, for their day-to-day practice. So can you see me here?
Yes, ma'am.
Yeah,
Slides are
yes,
visible.
Yes, Varsha.
Thank you. So with continuation with JK madam's, Jayam Kannan madam's talk of sudden obstetric collapse. This Bundle of obstetric hemorrhage safety was maternal bundle safety bundle of obstetric hemorrhage was formed, and it is really very much useful to decrease the mortality and morbidity of this hemorrhagic shock or the sudden collapse, and more mortality due to morbidity also due to delivery and dealing with obstetric emergency. So we have to anticipate it. So how it should be done, that is what we are going to talk. This is my actual new CV, but it's okay. The objective of this talk is describe the magnitude of the problem, take a look at the processes, methods, and tools that were used to develop the obstetric hemorrhage patient safety bundle, provide an overview of bundle components, give suggestions for how to effectively implement and utilize bundle within your organization. You may be having very small setup, private setup, or big setup, 10-bedded hospital, 25, 50. Accordingly, you have to manage the and be prepared and identify resources to customize for use within your organization. So it is very imperative that we should be ready to deal with such emergencies. Obstetric emergency traditional definition is more than 500 ml after vaginal birth and more than 1 liter after C-section of the blood loss. ACOG definition tells us that if more than 1 liter of cumulative blood loss or blood loss accompanied by signs and symptoms of hypovolemia within first 24 hours after delivery, regardless of your route of delivery, that is obstetric hemorrhage. So incidence is approximately 4 to 5% of the births. Now, friends, looking at this maternal morbidity and mortality chart, the causes are like different from amniotic fluid embolism or venous embolism or infection, hemorrhage, preeclampsia, cardiac diseases are the commonest causes for maternal mortality or severe morbidity. And of them, hemorrhage is the most mortality is 15%, giving mortality of 15%. The ICU admissions, about 30% people need ICU admission, and severe morbidity afterwards is above 45%, which is very grave. So why the women are dying from? What are the pregnant women dying from? We have to save the mothers' lives. So we have to focus on the causes, why they are dying from. 28% are dying because of pre-existing medical condition exacerbated by the pregnancy, such as diabetes, malaria, HIV, obesity. 27% die because of severe bleeding, 14% because of pregnancy-induced hypertension, 11% because of infection, mostly after childbirth, 3% die of blood clots, abortion complication 8%, and 9% because of obstructed labor and other direct causes. This is the figure given by WHO. So what are the etiologies of obstetric hemorrhage? We all know, but brushing up of knowledge, our knowledge, uterine atony, 80% of the total, genital tract laceration, abnormal placentation, previa, morbidly adherent placenta, abruption, retained placenta, uterine inversion, that is what Madam already told us, and maternal coagulopathy, it may be hereditary or acquired. So what are the complications of this obstetric hemorrhage? Anemia, we all know that. Anemia, hypovolemic shock, consumptive coagulopathy, acute renal and liver failure, acute pulmonary edema, transfusion reactions, Sheehan syndrome because of loss of less blood flow, postpartum pituitary necrosis, myocardial ischemia, and death. Failure to recognize excessive blood loss during childbirth is the leading cause of maternal morbidity and mortality. Women dying from obstetric hemorrhage because of lack of early and effective interventions. So we have to address the problem, and there is the development of patient safety bundles. So what are they? That we will be seeing. How it happened? ACOG CDC maternal mortality or severe morbidity action meeting occurred in Atlanta in November 2012. Participants identified key priorities like core patient safety bundle, obstetric hemorrhage, severe hypertension in pregnancy, venous thromboembolism prevention in pregnancy, supplementary patient safety bundles like maternal early warning criteria, facility review, family and staff support, and 6 multidisciplinary working groups were formed. Council of Patient Safety was formed in July 2013, which endorsed the concept of 3 maternal safety bundles. This bundle represents outlines of recommended protocols and material important to safe care, but specific contents and protocols should be individualized to meet local capabilities or local or the private hospital capacities. Hemorrhage safety bundle details were endorsed by the council in July 2014. So the goal of obstetric hemorrhage patient safety bundle is improve readiness to hemorrhage by identifying standardized protocol, general and massive. Improve recognition of obstetric hemorrhage by performing ongoing objective quantification of actual blood loss. Improve response to hemorrhage by utilizing unit standard stage-based obstetric hemorrhage emergency management plans with checklists. Improve reporting systems, learning of obstetric hemorrhage by performing regular on-site multi-professional hemorrhage drills. So 4 domains of patient safety bundles. First is readiness, then recognition and prevention, response, reporting system, and learning. So readiness. We all know about hemorrhage cart, which is immediately available antepartum, postpartum, multidisciplinary input for development, stocking and maintenance, containing supplies, checklist, instruction card for intrauterine balloon and compression stitch. This is the typical hemorrhage card. So recommended instruments for the hemorrhage card, if there is for vaginal delivery, vaginal retractor, long weighted speculum, long instrument like needle holder, scissor, Kelly clamp, sponge forceps, intrauterine balloon, benzocairate, bright task light, and procedural instruction how to do the how to insert the balloon and etc. Now, for cesarean laparotomy, hysterectomy tray, number 1 chromic or plain catgut suture, reloadable straight needle if you want to take the B-Lynch or other sutures, intrauterine balloon, procedural instructions for doing the balloon, in B-Lynch, arterial ligations. Readiness, immediate access to hemorrhage medications. The kit, medical kit or equivalent should be available. Consideration including safe storage, access time to bedside bedside in drills. So recommended medication kit is we have to have premix oxytocin, in IV fluid, pitocin, methotrexate, carboprost, misoprostol, methotrexate, and now carbitocin also is added. These few of them need refrigeration. We all know that. Refrigeration, we all know that. Now, hemorrhage response team. Drills and education for teams are critical. Surgical and critical care support. We have to have gyno-oncology. Dr. Gayatri already told us the team efforts are very important. Gyno-oncology, maternal fetal medicine, general OBGYN, critical care person, general surgeon, urologist should be, the team should be ready for each, to face each and every emergency. Anesthesia support, second and third person, nursing support, additional staff, administrative support, blood bank and laboratory staff. So blood bank massive transfusion protocol. In order to provide safe obstetric care, institution must have functioning massive transfusion protocol, have a functionally emergency release protocol like minimum of 4 units of O negative or uncrossed packed cell RBCs, have the ability to obtain 6 units of packed RBCs or 4 units of FFP compatible or type specific for bleeding patient, have a mechanism in place to obtain platelets and additional products in a timely fashion. Now, unit education on protocol and regular multi-unit based drills with debriefing is very, very important. Familiarize all team members with entire safety bundle and new management plan, identification of correctable systems issues, and practice team related skills. So next is recognition and prevention. So the anticipatory planning is very, very important. So how we can do it? Assessment of hemorrhage risk, measurement of cumulative blood loss, active management of third step of labor. These all allow for anticipatory planning. Now this is the flow chart of the procedure, prenatal admission, what you should do. So on admission, Admission hemorrhage risk assessment tool is like low risk, medium risk, or high risk. When the patient gets admitted, you have to evaluate her as a low risk if she is a singleton pregnancy, less than 4 previous deliveries, unscarred uterus, or absent PPH history. Medium risk patient is who has previous LSCS or uterine surgery, more than 4 previous deliveries, multiple gestation, large uterine fibroid, history of chorioamnionitis, morbidly obese patient, BMI more than 35, estimated fetal weight is large, more than 4 kg, and history of PPH. The high risk patient is previa, acrita, incrita, percrita, placenta having these problems, hematocrit less than 30, bleeding at admission, known coagulation defect, platelet less than 1 lakh, abnormal vital signs like tachypnea or hypotension. We all know measurement of cumulative blood loss, but formal, accurate measurement is done by calibrated drapes and canisters. Weighing blood soak and items and clots, visual assessment of blood loss is also very imperative and important. So we know how to do it with blood loss by obstetric hemorrhage by this chart. Active management of third stage is very, very important. Initiation of IV or IM oxytocin immediately upon delivery of anterior shoulder of the baby, either at the time of vaginal or C-section. Other components include research and clinical protocol have included control contraction and vigorous bundle muscle. Oxytocin is a key element and other components not proven to impact blood loss. Now, response for early hemorrhage. Unit standard stage-based obstetric hemorrhage emergency management plan with checklist is very much important. Support program for patients, families, and staff for all significant hemorrhages, because it's a crisis not only for the patient, for the staff, for the surgeons, for the multidisciplinary team also. So these are the stages when we should intervene, what we should do. So let us see one by one. Now for stage 1, the blood loss, if there is a blood loss of more than 500 ml, if it is vaginal delivery, or blood loss more than 1 liter C-section with normal vital signs or lab values, we should do, the initial steps should be ensure 16 gauge or 18 gauge IV access, increase IV fluids crystallites without oxytocin, insert indwelling urinary catheter, and bundle massage is imperative. Medication, in case oxytocin, add additional uterotonic. These are the medications in the here that they are oxytocin, methadone, carboprose, misoprostol. That is very, very important to have it in the hemorrhage card. The blood bank or type and cross-match 2 units of RBCs. Action is to determine etiology and treat. Prepare OT if clinically indicated. And these 4T, we all know, atony, trauma, we have to see for laceration, tissue, retained product, and thrombin. Look out for if there is any coagulation dysfunction. Now stage 2. Continued bleeding if it is there for more than 1500 ml or more than 2 uterotonics with normal vital signs and lab values. Initial step is mobilize additional help, place second IV, 16 to 18 gauge, draw blood for CBC, coagulation factors, fibrinogen estimation, and prepare for operation theater. Medications, continue stage 1 medications, blood bank, obtain 2 units of RBCs, do not wait for labs, transfuse preclinical signs and symptoms, or 2 units of A50, and action is escalate therapy with goal of hemostasis. Until and move to stage 3 if continued blood loss and or abnormal vital signs. Now, intrauterine balloon technique, insert under sonography, inflate up to 500 ml with sterile water or normal saline, use vaginal packing, hydroform or antibiotic soap gauze to maintain correct placement and maximum tamponade. Gentle traction to be given to this balloon and secure to legs, patient's legs. If not, if surgeon medical management is not enough, you have to go for surgical management like placental plate suture, uterine artery ligation, uterovarian ligation, repair uterine rupture, Beeline suture or other suture or multiple square sutures to achieve hemostasis, and lastly hysterectomy. Now the next stage is continued bleeding if more than 1500 ml or more than 2 units of RBCs given, still the patient is bleeding or the patient is risk of occult bleeding, coagulopathy, or the patient with abnormal vital signs, abnormal lab reports or oliguria. The initial steps is mobilize additional help, move to OT, announce clinical status, vital signs, cumulative blood loss and etiology, outline and communicate plan, medications as given on the right side, and continue stage 1 medication, that is oxytocin, methadone, carbopros, misoprostol, ursocarbotosin we are now using. Initiate massive transfusion protocol. If clinical coagulopathy and cryoprecipitate, consult for additional agents. The action should be achieve hemostasis intravenous based on etiology. Interventions based on etiology. So the checklist for this final stage is cardiorespiratory collapse, massive hemorrhage, profound hypovolemic shock or amniotic fluid embolism. Initial steps are mobilize additional sources. Medications are advanced cardiac life support. Blood bank, simultaneous, aggressive, massive transfusion should be given, and action should be immediate surgical intervention to ensure hemostasis with hysterectomy. Now, the vital stage staging is with continued bleeding with effective blood loss more than 1500 ml. This is the last stage, more than 2 units are RBCs given, packed RBCs given, or patient at risk for occult bleeding, coagulopathy, or patient with abnormal, so this is the last stage, and we have to do immediate surgical intervention to ensure hemostasis or hysterectomy. So the response on post-hemorrhage management. Determine disposition of patient, whether to shift her to ICU, but whether to shift her to ICU. Debriefing with whole obstetric care team is very, very important. Debrief with patient and family, and document is very important. Support program for patient, families, and staff for all hemorrhages, as it is the traumatic event for all of us, even the patient, family, and even the hospital staff and everybody. So, reporting lastly, the systems learning every unit is very, very important. Establish a culture of hurdles of high-risk patient and post-event debriefs. Briefs, hurdles, and debriefing becomes a part of routine. We have to retrospectively assess the patient, what went wrong, what we have to do, what would have done more to achieve better outcomes, and we have to discuss that with the team to improve the role of clarity, situational awareness, and utilization of available resources. So multidisciplinary view of serious hemorrhages for system issues, formal meeting to identify any systems issues or breakdowns that influence the outcome of the event, multidisciplinary perinatal quality committee, sanctioned and protected, monitor outcomes and process metrics in perinatal quality improvement of the committee, process measures used to document the frequency that a new protocol is used, outcome measures used to determine project success. Goal is to reduce the number of hemorrhages that result in severe maternal morbidity or mortality. Follow internally 4 or more units of packed RBCs and require ICU care. So now, friends, we all know, because of government policies, because of FOXY awareness and trainings and Manyata has really revolutionized our staff. They have become more confident, their body language has changed, and they do the drilling, PPS drilling and whatnot continuously in that the phase of education, continuous education, and so more confident they are to deal with. And it is like not only my hand, but so many hands ready to help me in crisis. So Manyata is really, I salute to Manyata, the really good initiative by FOXY, and to help the paramedical staff even in private. So India has having falling MMR still, like Dr. Kavita Bapat mentioned, the MMR is still high, but in India more than 100 in few pockets of India. We have to make it lesser and lesser, but definitely it will be more improved by days coming. So the conclusion, dear friends, early opportunities exist to assess risk, anticipate and plan in advance of an obstetric hemorrhage, and you can definitely reduce maternal mortality and maternal morbidity too. Multidisciplinary coordination and preparation, particularly with blood bank, is critical in order to provide safe obstetric care, and standardized approach to obstetric hemorrhage includes a clearly defined stage checklist of appropriate actions to be taken in an emergency situation and can help to improve patient outcomes. Thank you for your patient hearing. This is my hospital with IVF and all everything in it. So, dear friends, I will look forward to you declaring my candidature for Foxy Vice President West Zone. You have to give 2 votes. One of it should be mine. मेरा चेहरा देखना और सिक्का मारना. Thank you for so much. Thank you for being here so much.
Thank you, ma'am. That was quite a drill with a rapid lot of points to take in. Thank you so much for going through it very fast. The whole talk itself was like a drill. I think nothing was missed, and thank you.
Thank you
Thank you so much, ma'am.
Dr. Nirmala.
Thank you so much, ma'am, for excellent
All the
talk
best,
regarding
ma'am.
PPH.
And all the best, ma'am.
Thank you, Jasmine, Rajesh.
Thank you, ma'am.
I think,
was really
Nimi,
nice.
Nimi, you can introduce the next panel moderators and all. Your the same team
Oh,
can
yeah.
introduce them.
Yeah.
Okay.
Okay.
I will take over.
Okay,
Now,
Varsha.
Sure, ma'am.
You want to give somebody? I didn't hear
No,
it.
they
Sorry.
are
No,
three.
ma'am, no,
There
ma'am.
three are there, no? Jasmine is there.
No, take.
Yeah, ma'am.
Somebody should. You
Yeah,
tell.
that's
You
right.
tell
That's
somebody.
what I thought.
Yes. So pleasure to introduce the beautiful Jairani ma'am. So she's the senior consultant of reproductive medicine at Akash Fertility Center, Vadapalani, and also a member of every society, including ISAR, Foxy, and also ASRM and ISHRE. She's got the Best Doctor Award from the MGR Medical University, the Rajamani Janaram University First Prize in Obstetrics and Gynecology, Dr. Badamalayan Endowment Gold Medalist in MBBS, the Dr. Anantachari Prize for the University First Gold Medal in DGO, awarded the Woman of the Year in 2010 by Lions Club, as well as Achievement of Yeoman Service Award by Exnora, with a lot more achieving award. Congratulations, ma'am.
Thank you, Nimi.
And then we have Charmilaka, Vice President-elect of Foxy 2024, and also the chairperson for the Clinical Research Committee, Foxy 2016 to 18. She's the ICOG Governing Council member 21 to 2023, the National Coordinator of the UNICEF Foxy PCA, MEDA Foxy PG program. She's also the series
Dr.
convener
Charmila,
of
thank you so
ICOG.
much for coming over here and gracing the occasion. You are Foxy
Yes.
Vice President, and I love you so much and thank you for obliging me. Thank you.
Yes, she's done a lot to putting this program together too. So welcome, Dr. Charmila. Next. And the panelists for today are first one is Dr. Radha Madhavi. She's the founder president of Thiruvannamalai OG Society and also the director of Rajam Multi-Speciality Hospital and Rajam Institute of Paramedical Sciences. She's the joint secretary and EC member of TNFOG and also a member of Foxy ISAR IMS. Dr. Shanti Rani is a professor and HOD of obstetric gynecology from Government Teni Medical College. She's also the president of the Teni Obstetrics and Gynec Society, founder treasurer of the Teni OG Society, secretary of Teni OG Society for the last 6 years, has been an organizing chairperson for a lot of societies, for a lot of conferences like Colposcopy 2015, ArtCon, Endogyne Teni, and is also the coordinator of medical disorders in pregnancy committee of Foxy. The next moderator is Dr. Manomani, and she is next panelist. She is the professor and HOD of Coimbatore Medical College Hospital and has been in the service of Tamil Nadu government for 26 years. She's the present president. She's a present president of COGS. So she is from Madras Medical College and was the best outgoing student of 1990 batch of MMC. She's a Johnson medalist from there and is also the Tamil Nadu State Best Doctor Award of 2019. Has a lot of publications and original research. It's also the COGS Managing Committee member of 2017 to 19, co-chair for Foxy. Thank you, ma'am. Then warm welcome to Dr. Reshmi Ajit from Nagarkoil. She's the current secretary of Nagarkoil Obstetrics and Gynecological Society, as well as a senior assistant professor of Kanyakumari Government Medical College and Hospital. Dr. R.B. Darga is from Virudhunagar West Obstetric Society. She's alumni of Baroda Medical College, and also she's come from Gujarat. She's a gold medal in her MD exam. She's also done laparoscopy training. She's a consultant at Vijaya Nursing Home at Sivagasi, and her specialty is high-risk pregnancy and infertility, and also a member of the Safe Motherhood Committee of TNF. So warm welcome to all of you, and good luck.
Thank you, Nirmala. Thank you so much for that kind introduction. It's an honor to be here with such eminent speakers as well as great panelists, because we will not consider you as panelists. We will be the opinion leaders, because all of them are great in their fields in different parts of Tamil Nadu. And it's an honor to moderate a panel where I have Dr. Jairani Kamaraj as my co-moderator and all the esteemed panelists as part of the panel. It will be a great learning experience for all of us. And I'd like to thank Varsha for the opportunity. And you should remember, Varsha, that Tamil Nadu is with you. All of us will vote for you.
Thank you so much.
And we
Thank
are
you so
with
much.
you
The
because
blessings from you and Charmila and all are very important for me.
blessings from
Thank you.
Jayamkanan madam is very, very important, and she's always with you. So all of us are there
Yes.
with you always. Thank you
Thank
so
you
much.
so much.
Yeah. And esteemed panelists, and I said opinion leaders of Tamil Nadu societies, Dr. Radha Madhavi, Dr. Shanti Rani, Dr. Manon Mani, Dr. Reshmi, and Dr. Aarti. It's an honor to be with you. I just go on to the first case scenario. This lady is a 26-year-old. She was posted for a fetoscopic surgery for twin-to-twin transfusion syndrome at 20 weeks of gestation. She had polyhydramnias, and she was obese. 45 kg per meter square was her BMI. The procedure was planned under a combined spinal epidural anesthesia. We took an IV access, ECG, pulse oximetry, and a NIBP monitoring was going on. We preloaded her with 500 ml of Hartmann solution. We did the CSE in a sitting position at L3 to L4 interspace. The epidural was placed at a depth of 7.5 centimeters. And the intrathecal dose of bupivacaine 0.5%, 9 milligram was given, and the epidural catheter was sited inside. We placed her in the supine position after the epidural with a wedge, and in 1 minute she became symptomatic. Blood pressure crashed to 60/30. Dr. Radha ma'am, what would be the management now when a patient where you put a spinal has crashed? Radha madam? Madam, please unmute yourself.
Yes,
ma'am. Yes, ma'am.
We will give her vasopressin.
Yes,
We'll make her IV line, which is, if it is the green Venflon they have put, we will go in for an gray Venflon.
Yes,
and all the day, breathing, circulation, airway, all those things will follow, and immediately we'll start giving IV fluids.
Okay.
And once we finish with all this, we'll go in for additional atropine. And make sure there is a wedge. We place a wedge.
We place the wedge also. The fluids were given. And as you say, the vasopressor was given. Still the BP dropped to 50/20. Patient was feeling dizzy and nauseated. How do I go ahead now? As you said, we put an additional IV access, gave another liter of Hartmann solution.
Tilt into, increase the tilt of the bed.
Because the wedge is not enough, so you'll go into full left lateral position to take off the aorta cable compression.
Yes.
Okay, the resuscitation was continued. And Dr. Shanti, 4 minutes post all that, whatever Dr. Radha madam said, she lost consciousness. Now, what do I do? Shanti?
Yeah, madam. Very good evening.
Is it a nice case, or you will also crash?
And this is a very good case, because most of the time we'll be meeting when the patient is giving spinal, and this is only one thing I want to say in the first answer, because you should immediately make the position as reverse Trendelenburg. You should head up the patient, and then that will make a lot of help.
We tried all that, Shanti, still she crashed.
Because that was not there. And now this is the situation, you should call for help. First, the blue code should be activated, and you should ask for help from all the sectors, from anesthetist, and also
anesthetist is already there.
Okay. You have to mobilize a team to work with. Okay. Then you have to, at this point, you have to intubate the patient.
Yes.
And you can add this dopamine or pressor drip infusions can be started, NORAD or dopamine can be started. And at this point, we want to empty the uterus
Yes,
so that
perfect.
resuscitation is possible, and it will be highly useful for the patient.
Yeah, so as you said, we went for a resuscitative hysterotomy. That was a question in the chat box also. What about perimortem cesarean section? So we went for a cesarean, not a cesarean, I'll say we went for a hysterotomy. And then after uterine evacuation, the pulses were palpable and the blood pressure became recordable. No further inotropes were needed, luckily, but the twins died later in an ICU. So we have to remember that the cardiopulmonary arrest in pregnancy involves two patients, and to remember that the mother and the fetus are at stake. You need a multidisciplinary approach, as Shanti said, and you need to follow all the basic and advanced cardiac life support algorithms which you have for your center. The protocol has to be in place. You cannot run about like a headless chicken when it happens. It has to be in place when you're starting, as Shanti said. You have to call for help, call whoever is available in the hospital so that you get the maximum help. But there are some modifications you will need for cardiopulmonary resuscitation in pregnancy. Manu, what are the modifications in the basic cardiac life support and the acute cardiac life support system in the pregnant patient? What are the modifications we need to do?
Good evening. In modification, there is so first thing is resuscitation. It is not like ABC. It is now what is circulation is the first thing we have to maintain. Yeah. If there is only one person, they should take care of the circulation. They should give effective cardiopulmonary resuscitation with the there is one thing, and we have to displace the uterus. It is MUD. It is manual uterine displacement should be done. If you are standing on the right side, you can lift and push the uterus towards the left, or else one person can go towards the patient left side and pull the uterus, lift and pull, so that the gravid uterus sitting on the aorta is being lifted up. So the peripheral blood would go into the circulation. So that is a one change. And there is no more left lateral position. Patient in supine position with the manual uterine displacement. Remember as MUD, manual uterine displacement. And we have to go 30:2 compressions. Compressions 30 followed by 2 breaths. That should be the thing. And if there is after 2 minutes, depending upon, and then by the time help comes in, so if it is pulseless or if shockable rhythm, depending on that, we can give either shock or we can go for again continuous compressions. So that is thing modification. There is no supine position. You displace the uterus, and even if after 4 minutes, that is 2 cycles of resuscitation. That is 30:2. There is no resuscitation, spontaneous reversal of circulation. We can go for resuscitative perimortem cesarean section. That's what Madam was describing. Actually, we did 2 cases here in Coimbatore Medical College in the past 6 months, and 1 patient survived, and 1 patient we couldn't make a survive. So this is what has been happening.
Yeah, thank you. I would like to Reshmi to just sum up the steps of resuscitation which all the panelists said. Reshmi?
Madam, first you have to activate the maternal ward team, call for help. Resuscitative equipment should be ready. Document the time of cardiac arrest. Make sure 100% oxygen with mask is given. Suppose that it has happened, suppose there is an epidural infusion going on in a normal delivery, it is better to stop the infusion. If magnesium sulfate has been given, better stop the magnesium sulfate, discontinue it, and patient should be head up in reverse Trendelenburg position. Assess the airway, breathing, circulatory system. If the airway and breathing is compromised, intubate and immediately.
Perfect.
If there has been a circulatory compromise, then you go for, if there is bradycardia, treat with atropine. If there is hypertension, make sure that you rush in crystalloids, IV fluids. Vasopressors like ephedrine can be given 60 milligram. Phenylephrine 100 microgram can be given. In severe hypertension requiring high doses of epinephrine, might require high doses of epinephrine around 50 to 100 milligram.
Hypotension, yes.
300 milligram bolus can also be given.
What are the precautions you will take in airway and breathing for a pregnant patient?
Airway.
You need a very skilled provider because she's pregnant, and
the patient should be shifted to the left uterine displacement.
It will be a very difficult intubation, so you need the best person available in your center to come. And circulation, as Mano said, chest compression should not be delayed at all. Just because she's a pregnant patient, you start, and 30:2 is the one you start. And plus, please remember, it may not be effective in all your patients when it's more than 20 weeks because the pressure is too much, and the pressure on the diaphragm is also much higher. So that's why resuscitative hysterotomy, you need to resort early when your resuscitative measures are not working. Dr. Aarti, like other than this CPR, like regarding the fluids and defibrillator which can be used in pregnancy, what are your thoughts on that, Dr. Aarti?
Yeah. Good evening, everybody.
Good evening, ma'am.
So we have to give IV fluids very fast, ma'am.
Yeah.
Because in these patients, like only after 1 hour, only 20% of the IV fluids will be there in the circulation. So about 2 liters, we have to normal saline, and ringer lactate, you have to rush fast. And if necessary, colloids also can be given. And like blood has to be arranged fast, because in order to...
No, that will be in other conditions where you had a hemorrhage, not in such a patient who's collapsed after a spinal anesthesia. And the fluids, we should not give lots, because that can cause pulmonary edema, because you need more of vasopressors now to pick up the circulation. So that's one thing. And what about the defibrillator? Is it dangerous for a pregnant patient? Can you give a shock for a patient who's having an arrhythmia?
No, we can give, if there is a VT or VF, we can give defibrillation. And basically one of the it will be there on the sternum and the other on the cardiac apex. So the heart should be there in between both the defibrillating this, and the same dose can be given to a pregnant woman. Yeah.
So do not get worried about the defibrillator. You can use it for a pregnant patient even if there's a baby inside. But remove the monitor, because that can cause injury to the mother when you're giving a shock with that. And there is difficulties in resuscitation. We already talked about that. And remember that the feto-placental unit will consume more oxygen, and that's why high oxygen has to be given at high pressures. The weight gain of pregnancy of the mother, the large breasts, will inhibit the workspace, and the laryngeal edema will contribute to a difficult ventilation. And that's why you need the senior most intensivist to help you out with intubation. There's always a higher risk of aspiration in these women because of a relaxed esophageal sphincter. There will be delayed gastric emptying, which will also contribute to a problem there. And remember, the uterus releases almost 10% of the cardiac output at term, and this can lead to loss of large volumes from the uterus very rapidly. Dr. Radha, madam, what is it? Why is that 4 to 5 minutes rule in perimortem cesarean delivery? Why should you not wait beyond a particular time to do a perimortem cesarean section?
Ma'am, after 4 minutes, definitely there will be brain damage, and to recover the patient, it will become difficult.
What was it based on? Any studies were there which said that 5 minute golden minute or something like that? Was there something like that in pregnancy?
4 minutes of CPR, they should, if she has not come on to a spontaneous circulation, has not got established, we have to definitely do the perimortem cesarean. And
yes, ma'am.
And this is immediately within 5 minutes we have to do the cesarean section. Umbilicus to pubic symphysis, vertical incision is taken because the easiest entry into the abdomen, and you do as rapidly as you can and within 5 minutes, so that it improves the cardiac output return to the mother. So many times after perimortem cesarean, they just recover, and baby also we would be able to save. As Manon Mani ma'am said, she saved both mother and baby with this.
And actually, there are no studies on pregnant patients regarding this 4 to 5 minute rule. It is all based on non-pregnant patients where irreversible brain damage happened when there was anoxia for 5 to 6 minutes. And remember, in a pregnant patient, it's going to happen much earlier in a pregnant patient. So, in a patient who's collapsed and you said does not have a circulation, do not wait and thinking that it will pick up again. You need to go for a hysterotomy as fast as possible. And there are evidences to show that when you empty the uterus, it relieves the aortic cable compression. It causes almost a 60 to 80% increase in the cardiac output, and this increases the likelihood of maternal survival. Dr. Shanti, like you've done it, so I would just ask how to perform the surgery. Radha madam has mentioned. Where will you perform the surgery? Will you need to go to the theater? And do you need a consent? And from whom you need the consent for a perimortem cesarean delivery?
The perimortem cesarean delivery should be done at the site of collapse. Wherever it is. So we should be prepared in the places. We have to set up only one blade and two arteries needed. So we should keep it ready wherever we are expecting a maternal collapse in our hospital setup. So it is in the casualty, it is in the labor room, it is even in the antenatal ward we are having, because wherever the place we are expecting a collapse, there should be, and it should be done at the site of collapse, not to shift the patient to that of the OT. It is not at all necessary. And how to perform the surgery, madam had told it should be done in the lower, whatever, how to access to the abdominal cavity as early as possible, that should be done. And the incision on the uterus is depending upon the skill of the obstetrician. It is need not be always a classical. You can do a low segment incision without pushing the bladder and all. And regarding this closure and all, after resuscitation, you can shift the patient. That's what usually we do in a government setup. We'll deliver the baby in the labor ward itself, and then after that, we'll after this heart rate picks up, we are shifting the patient to the theater. We are closing that. But when it is not possible, when it occurs in the labor, other places, you can do the closure also in the same setup. Consent needed from whom? There is no need to get a consent from the patient or from the nearby kin. There is no need, because this is a necessity for the patient rather than, and madam was telling, if you are not doing perimortem cesarean at time, you can be sued or you can be blamed for not doing it. Nowadays, the legal aspect is like that. So there is no need for consent.
Yeah, perfect. So transporting to the theatre is not a priority, as Dr. Shanti said. There's no need to administer any anesthesia. Patient is already collapsed. You do not need anything. It can be done without consent in the United States, unambiguous there. There was an ambiguity here, but now they've said there's no need for consent in India also. There's no physician liability because it's a maternal cardiac arrest and you need to save the mother. Method of surgery, as all the panelists said, will be a vertical incision or any other incision should provide the fastest entry into the abdominal cavity. Needs an adequate uterine exposure. Access to the diaphragm is also available when you give a vertical incision, because you can resuscitate the mother through the abdominal cavity. Bleeding is minimal, so don't worry about it, because it's there's a maternal hypoperfusion which will cause a reduction in bleeding. Intraoperative care, as Shanti said, ideally should be shifting to a aseptic area, but if not possible, close it there and remove the placenta, close the hysterotomy suture, close the hysterotomy site, and oxytocin should be started the moment you deliver the baby, because you need to avoid PPH, because she's going to go for PPH also. But do not give an IV bolus, which will cause more of hypotension. So success of survival in this condition is the underlying etiology of the arrest, the maternal location at the time of the arrest. Suppose she's arresting inside the hospital, you've got a high chance of saving her. The speed of your resuscitative efforts, and that's why the protocol for this, the code which you're calling for, should be on par, because you cannot miss managing a person who's collapsed in the pregnancy, and the skills and resource of the healthcare provider is extremely important. Dr. Jairani, do we have time for the second case, or Dr. Jairani?
I think let Jairani take over, because we have little less time. Is it okay, Dr. Charmila?
No problem. Yes. Thank you. Thank you.
We'll finish
You
up
can
our
take
case
it fast otherwise.
Yeah.
I can, otherwise I'll just say fast and finish it off. And
Yes,
Dr. Jairani can.
Sure. No problem.
Okay. So
You're
this
doing
lady
so
is,
well, actually.
yeah, this lady is gravid at 2 previous normal delivery, GDM in her first pregnancy, over diabetic on insulin, and she was admitted for induction. She had a good glycemic control. It was induced with Foley's followed by prostaglandin gel. 4 hours after second gel, she started having contractions. She was on continuous monitoring, and she ruptured a membrane spontaneously 5 hours after the gel application. On examination, uterus term acting, first 35 seconds, head and unengaged, cervix well effaced, 4 centimeters dilated, membranes absent, vertex -3. 15 minutes after the spontaneous rupture of membrane, the patient becomes unresponsive. So Dr. Manonmani is an expert in amniotic fluid embolism. Mano?
Yeah.
We'll make it fast.
Patient, this patient is a GDM big baby. She was given ARM. So it is unresponsiveness suddenly with 4 centimeter dilatation in labor or within 30 minutes of labor. You have to first think of amniotic fluid embolism. But it is, unless proved otherwise, you have to think of again rupture, because she is in 4 cm dilated, GDM big baby anticipated. So first and foremost, you have to rule out rupture. But then this disproportionate hypotension and unresponsiveness, you have to think of amniotic fluid embolism only. So for that, we have to be ready, and the team should be ready, and we should do a teamwork to make the patient resuscitate, or else we'll be losing the patient. So if she has to deliver, then we have to think of rupture uterus, as well abruption, as well the any postpartum hemorrhage, because within half an hour patient collapsing, first and foremost, I would rule out the any atonic PPH or any of the traumas.
Because she's not delivered, it will be more of antepartum hemorrhage.
Antepartum hemorrhage or rupture.
Traumatic, all the T's, thrombin,
Uterus,
trauma, tissue, anything is a reason there. Reshmi, like, how do you think amniotic fluid embolism happens and how does it progress when the patient is in labor?
It is
like, I want to know the sequence in a short, because when you ask your student, they want to, you want them to answer in a short this thing question.
Yeah. Okay, maternal, because it is because of the exposure of the fetal tissue into the maternal vasculature, there is an increased risk of amniotic fluid embolism. And it can happen anytime during labor, during the time of delivery. It is most commonly, it happens during ARM, during cesarean sections, septic abortion, etc. It actually what happens is it triggers an abnormal activation of the humoral and immunological mechanisms and the release of vasoactive and coagulant substances. It is otherwise known as the rheumatoid syndrome of, there are two types. It could be either a cardiopulmonary collapse or a DIC type. Anything can happen. Like most commonly in pregnancy, the DIC type is seen. Initially, there will be a respiratory reaction, vasospasms, with vasospasm causing breathlessness, coughing, anxiety. Vasospasm can lead to pulmonary hypertension, bronchospasm.
Have you witnessed one, Reshmi? Have you witnessed an amniotic fluid embolism?
Yeah, yes, madam. Yes, I have.
Okay.
We have.
So what was there in that patient? What did she manifest with?
She immediately, actually, it was DIC. DIC was the first symptom which came.
Okay.
Actually, this happened when we had done an ARM and we had also given epidocin.
Did she come out alive? No, did she come out alive?
No.
You could save her?
No, she didn't.
No.
She didn't.
So what did you think you missed there in management? Because you diagnosed amniotic fluid embolism. Where did you miss?
Sorry, madam.
It's a very high mortality, even in a well set up.
What I'm saying, it happens, but we retrospect, thinking like we could have done something better. That's what I'm asking.
The thing is, we have to think amniotic fluid embolism at back of the mind, and the hypertension should be taken care of, and DIC part should be immediately corrected. Unless we think it is amniotic fluid embolism, you might miss, because you'll be thinking that either she had gone for rupture or PPH. And then that sequence of events will be very fast. So unless we are prepared for that and the entire team moves in.
Usually we call it as a Kupatoti diagnosis. Whenever you don't have a diagnosis, you say it's amniotic fluid
ultimate diagnosis.
Ultimate diagnosis, because it may be cardiomyopathy, it may be, always you put these two. Like when you don't have a diagnosis, either it's amniotic fluid embolism or cardiomyopathy.
But
that's
nobody
why I'm asking Reshmi, in what made you diagose amniotic fluid embolism? You said DIC part was more and it was sudden, happened within 30 minutes. So what I'm saying, you lost the patient, but what was one thing you thought could have been done better? Because that's for the audience I'm asking. Because you are all practically
probably, madam, we were confused. Yeah, we were confused between whether this valethamine bromide has caused a sudden shock and symptom.
Okay. You thought it was a drug reaction, and that's the reason she went into collapse.
It was amniotic fluid embolism. We came to a diagnosis of amniotic fluid embolism only. We suspected AFI only when DIC started setting in. Within 15 to 20 minutes, DIC started setting in. We tried to take the patient and do an insection. But then we couldn't revive. Post-operatively, we couldn't revive the patient.
So, like, did you do it within that 5 minutes of a collapse?
Also,
the cesarean section? No, cesarean section you did within that 5 minutes?
So, like to transfer the patient to the OT, and probably in 15 minutes must have done it.
Yeah, so that's why I'm saying, like, before the DIC sets in, you deliver the baby, probably. I don't know, because
probably our diagnosis, there was a delay in diagnosis.
Delay in the diagnosis.
Because only after DIC set in, we took the patient for a cesarean.
Yes. Dr. Aarti, like we have already talked about this. So I just like to ask you, for this patient, we started CPR the moment she collapsed. Code blue was activated. She was intubated within 2 minutes. We shifted her. We actually shifted her very fast, delivered a 3.7 kg asphyxiated baby. Baby was intubated and admitted in ICU. I'd like to ask Aarti, like, was it right to do an emergency cesarean delivery? You talked so much about it, Dr. Aarti.
Yeah. It's very important, ma'am. because only after the cesarean delivery, the patient is going to show good improvement, and plus we'll be able to save the baby also. So
Yes.
that was very good. And plus now we'll have to take care of the, like, oxygen has to be given to the patient. This treatment is symptomatic. We have to put the patient on ventilator, and the DIC management has to be done. Like we will have to give PAT cells and FFP, and
you have to activate your massive transfusion protocol. Your MTP should start. Yeah. Radha ma'am, are there any investigations to actually, because Reshmi said the diagnosis was delayed, like any investigations could have helped to guide the therapy, or any special investigations are there to confirm?
The most important, I would say, is thrombin time, a clot thing, and CPC electrolytes will send as it is.
How fast will you get your coagulation profile reports in your hospital?
That it will take time, ma'am. It will take almost 1 hour. But
Nothing
thrombin time just comes within 20 seconds.
20, okay. So you can do something to just check out whether she's going into DIC. These are all investigations which are in research method, my modality. Mano or Shanti, are you having this in your centers?
No,
Zinc, corpopyfrin, Silil? No, nothing is available.
Complement factors are given in book, but routinely we are not.
It's not available at all. So any other supportive measures, because patient has gone for a cardiorespiratory collapse and she's having a DIC. Also DIC, Dr. Aarti said she'll go for a massive transfusion protocol. This you do a transthoracic or a transesophageal echocardiography to find out the failing of the right ventricle.
Usually the first investigation it is available with this is only echocardiography when the patient collapse. So echocardiography. If you see that this right ventricular strain, then we will think about this amniotic fluid embolism or any embolism for that matter.
Practical as an obstetrician, what is the difference between management of right ventricular failure and left ventricular failure in pregnancy?
Actually, at that point, when the patient is suddenly collapsed, right ventricular strain, that indicates a embolism. Either it could be an pulmonary embolism or an amniotic fluid embolism. If it is a left ventricular strain, we more roughly think of a PPCM. At that point, the patient won't have a sudden maternal collapse, but she will become the same symptoms, dyspneic and this tachycardia and fall of BP. So that immediate investigation right now in our hand is only this thing.
No, what I'm saying, the management. See, they're talking about right ventricular failure and left failure and all that. Like, is there a change in the management?
It is only supportive. There is no specific management. It is only supportive, and we have to give the pressors as well as fluid. But we have to be very careful that when you are doing a fluid management, because we cannot rush the fluid in like all the other cases of collapse. We have to put a CVP and monitor, because if you overload them, both she will end up with a cardiac failure. So that fluid monitoring and pressors, that is the most important management. And also regarding this, next you are expecting a coagulation cascade, this DIC next. So you have to alert the blood bank regarding this massive transfusion, and you can use a tech nowadays, thromboelastogram, to give what is the component should be given, not to overload with all FFP, all cryo. You should not put everything in a gush.
That point I wanted the emphasis on what Shanti is saying. Right ventricular failure and left ventricular failure, your problem is fluids. So don't overload a person who's having a left ventricular failure, going to aggravate the condition. And that's why when you identify a right ventricular failure, you can give fluids for a point of time, but for left ventricular failure, you have to avoid. Actually, you have to not avoid, you have to restrict the fluids. And that's why a central line is very, very important. When you have,
or else we can use IVC diameter also.
Yeah, you can see the IVC and you can find out about how much the right ventricle is going for a failure. And the point is you have to restrict your fluids, give more of vasopressors now, because vasopressors is going to help out for both the failure of the right ventricle and the left ventricle. Do not overload her, because that's going to cause. That's why you need if suppose arterial line you can get, that's the best thing you can do. But if you're not, at least a CVP you should have to find out what's happening. And if available, a transesophageal echocardiogram that will pick up that right ventricular failure for you very fast. But vasopressors should be the modality of treatment and not fluids beyond a point of time. Do not overload her. Thinking a hypotension will pick up with fluids, it will be the vasopressors which will actually help her. And this patient, after all the resuscitation, now she started having repeated cycles of maternal bradycardia. Vasopressor support was given. Echo showed a grossly dilated right atrium, right ventricle with a compressed left ventricle. Precautions in management, Dr. Shanti has already mentioned, avoid excessive fluid resuscitation as pulmonary edema can develop. And you have to maintain the blood pressure, the mean arterial pressure around 65 millimeters of mercury for a good outcome. Suppose she's got developed fever, it's going to worsen the injury to the brain, and that should be aggressively treated. Do not give her excess of oxygen again and again after she has survived the cardiac arrest, because that will worsen the injury. And maintain the pulse oximetry level around 94 to 98%. Maintain her blood sugars, because she can go for hypoglycemia, and that should be around 140 to 180 with the use of infusions. Right heart failure we already talked about. Mano, would you like to add something? Because I think we're finishing now.
Yeah, that's what the fluid management should be proper. If you cannot get a central line immediately, even we can, with the echo available, we can go for IVC diameter. I will maintain at 10 to 12 so that we don't overload and put the right heart to the stream.
Yes. And these are the drugs which are recommended for acute right ventricular failure. Coagulopathy, Reshmi, we said, Dr. Aarti said she'll go for a massive transfusion protocol. What is the protocol in your hospital?
Madam, we normally, before, only if the PTT is deranged, it is more than 1.5, or if the serum fibrinogen is less, then we have to go for the massive transfusion protocol. And if platelet is more than 50,000 and there are no, and only if there is symptoms of bleeding, we go for platelet transfusion. Because we normally don't. And the rate normally 1:1:1.
I think we should hand over to
I'm finishing now. This is the last slide.
Sorry to interrupt, Dr.
We are finishing.
Because we are nearing 10 o'clock now.
Dr. Aarti, regarding defibrillation, already we have talked about it. So suppose the rhythm persists even after 2 shocks, you need to give epinephrine 1 milligram. And ECMO, I don't think it's available at this point of time. But when there's a prolonged, you need a prolonged CPR after arrest, it's better to go for ECMO. And if there's a severe ventricular dysfunction, refractory to medical management, ECMO is needed. And this will be the pathophysiology. As all the panelists said, there will be a pulmonary vasoconstriction, and that's why the right ventricular failure is the first one to start. Acute respiratory failure is the second part, and the third will be the coagulation failure. And this is how you manage. For the emergency cesarean is always needed if the baby is not delivered for your CPR. For right ventricular failure, avoid excessive fluid administration. Consider norepinephrine to maintain the blood pressure rather than fluids. And you have to address the failure with inotropes such as dobutamine or milnacin. Same thing with the left ventricular failure. Fluid should not be overloaded. Give vasopressors. And coagulopathy may be immediate or delayed, and you have to manage with the massive transfusion protocol. Thank you so much, Dr. Jayarani. All the esteemed panelists who gave such great inputs. Dr. Varsha Basde for the opportunity. I'd like to wish Varsha Basde success in her journey. Thank you so much.
Thank you, madam.
So nice.
This wonderful panel.
Thank you, madam.
Beautiful.
Thank you for this opportunity.
Charmila.
Thank you,
You
ma'am.
are really a charmer, academic charmer, Dr. Charmila.
Thank you.
Charmila, you have become an internist and ICU specialist and anesthetist.
Actually, all government medical colleges, we are becoming intensivists.
Kama hospital बोल रहा था सब कुछ.
So,
Because with all
the
the
last
high
case,
cases,
Maybe
the last case we will have a real obstetric case. All these were managed by the internist and the anesthetist mostly.
Madam, usually what I say is I will never allow an anesthetist or intensivist to get into that picture at all. He will be only a part of it. And I will not allow any multi-speciality, the other departments to get into my field at all.
That's what I said. You have become an anesthetist and internist. That is the thing.
No, I will dictate terms. I will dictate
You are all in one.
Always the leader.
Charmila, you are all in one.
Always the leader.
Right.
Yeah, I know.
Because I've seen failures when you allow some other specialty to get, and you will not be able to help your patient at all because they think differently and we think differently. And ultimately, your patients, this thing is more important. Yeah, emotionally. You've seen about 9 months and it happens. I've stopped allowing an anesthetist to get into the picture at all for the past 10 years. I'm only doing it.
That's great.
I think you have to have a team which is with you for continuously for years. So you can have the well monitoring of the patient. If you have the team continuously for many years, you are really comfortable dealing with all complications.
That's why even in our private practice,
one
we choose them.
And one anesthetist. We do all cases, whatever it may come.
No,
That's
see,
why
what
we
I'm
choose
saying
anesthetists who work in an obstetric department mostly.
It's a luxury to have a team like that. That Dr. Shanti and Dr. Manon Mani must be having it, or Reshmi must be having. We do not have that luxury at all. So I choose the person who's helping me so that I know he will help me in emergency. And shifting also, I know where I will shift her so that I get the best maximum help, because in private practice, we cannot have such great teams which they are having in government hospitals.
Yes,
But
yes.
you learn from them. We ask
Excellent,
Shanti for
excellent,
help. We
Dr.
ask Manon
Charmila.
money for help and get it done. Thank you so much.
Madam. Thank you.
Yes, over to you, Dr. Jairani. Please take over. Thank
Yeah,
you
so
so
after-
much for this nice deliberation, Dr. Charmila. You are charmer, academic charmer.
Thank you. Thank you.
So after this case of anesthetist and interns, we'll come to our case of real obstetric case, where we will be seeing the. I hope I know that. Can you see my slides? Can
Yes,
you?
madam.
Yeah, we can see, Dr. Jairani.
So this is a case, a simple, straightforward case of a retained placenta. We were called, a senior resident was called for an emergency after the delivery of the baby, a delay in the expulsion of placenta. I would like to ask Dr. Radha, madam, how long will you wait? We'll have a quick firing questions because it is a very, very easy and interesting case and very easily can be manageable. And it is up to our level. We need not need any anesthetist. They may come as the last one. So we can add
15 minutes already up. Another 15 minutes, I'll wait. That's all.
Correct. So that is what, after the delivery of the baby, there is no definite consensus, but 30 minutes is considered the time to deliver the placenta. So retained placenta can be defined when there is a delay in the expulsion after 30 minutes. But the WHO guideline says that even you can wait up to 60 minutes. That is what they have given in multigravida. So that is what the WHO says, that you can wait up to 60 minutes after the baby has been delivered. So that is the placenta expulsion timing and the duration. The very important point we have to notice, when you have an AMSTIL, that is an active management of the third stage of labor, we have less chances of the delay in the expulsion of the placenta. But
Yes.
if you leave it for a physiological timing of the delivery of the placenta, then we may end up in a delay in the expulsion. So your AMSTIL is very important. The active management of the third stage is very important. So the next question to Madam Shanti, madam. So why the time limit, madam? What happens if there is a delay after 30 minutes for the placental delivery?
Actually, the incidence of postpartum hemorrhage is supposed to be more if you leave the patient after that 30 minutes. But actually, the chances of infection is also more when you're keeping the placenta for a longer time. But it all depends upon the case and the individual, madam. If the patient is very stable, hemodynamically stable, and she's not bleeding, we'll give some more time for the placenta to get expelled with some medical management. So we'll start a syntocinon, we'll give a misoprostol rectum, and it all acts wonderfully. Even after the 30 minutes, we wait and we'll start some drugs. So I think it depends on the case. Individual case and individual experience of the physician regarding this thing.
Yeah, as you're right,
usually the time limit is given because in general the incidence of PPH is more after when you wait for after 30 minutes.
Yeah, so that's it. So it's a time limit given just to plan things so that we don't waste much time in the planning of the next step of managing her. So that is why when she's getting delayed by around 20 minutes or 30 minutes, you will be planning for the next delivery, next planning of how we are going to manage her. That is a very important point. That is why they give a time for her delivery. So can any one of the panelists, can I ask Madam Manonmani, madam, can you tell me what causes this retained placenta, or when you expect or anticipate a retained placenta in a patient who is being normal, because this is a preemie normal, she's delivered very much normally without any other predisposing factors, but still she has a retained placenta. When you suspect women getting into a retained placenta?
The retained placenta could be either it is separated and it's not coming out of the uterus, or it could be a placenta adherent. So if it is going to be separated but not expelled, because sometimes maternal exhaustion, she is not pushing it out, or sometimes if you give uterotonics before the placenta starts getting expelled. So it might be, especially if we are giving methogen, it causes complete contraction of the uterus, including internal and external, so that it can retain or trap the placenta inside the uterus. So it could also be one of the causes. But simple adherent placenta is like, it is only attached to the superficial layer of the uterine musculature, which because of the atony, it is not getting separated. Sometimes prolonged labor, or it is over-descended uterus, polyhydramnios. The uterine myometrium goes in for exhaustion, so it doesn't allow the placenta to be separated. That could also be a cause for the retained placenta. But the last but dreaded one is the PIS, that is placenta accreta syndrome, or morbid adherence of the placenta, wherein it invades the myometrium and even up to goes to the percreta, to the serosa and all. So those cases are all the only very highly complicated cases. So simple retain.
Yeah. So I agree very well. As rightly pointed out by you, all these things can cause a retained placenta. So before getting into the retained placenta, we should know what is the normal physiological changes that happens in the placenta separation. So Dr. Rashmi, can you explain me what is the physiology of the placental separation?
Okay, madam, the placental separation, there are a few phases. First is the latent phase, where the uterus contracts except the portion beneath the placenta. Then is a contraction phase where the retroplacental myometrium contracts. Then it's a detachment phase where the contraction of the retroplacental myometrium produces stress to the maternal surface of the placenta, causing it to detach. And the fourth stage is the expulsion stage, where the myometrium expels the placenta. There's something called as madam had said, trapped or incarcerated placenta is the placenta is separated but does not come out because the cervix has begun to close.
Yeah. So I completely agree with you, Rashmi, that you have clearly said about the physiology of how it gets separated. So in a separated one, you get into the trap type of a placenta, retained placenta. And if there is an adhesion, then it can go for a simple adherent placenta or an accreta when it is severely invading the myometrium due to the defects in the deciduum. So Dr. Aarti, can you tell me what is the risk factors for the retained placenta? When you suspect or when you know that this woman can go in for a retained placenta, what are the factors you will keep in mind when you are managing her even antenatally?
So if a patient, she has got like previous surgery, previous cesareans, or she has got with previous cesarean, if there is low lying placenta or anterior placenta which is on the incision area, or previous myomectomy, or previous curettage has been done. If it's preterm, at term the separation is easy. If with preterm deliveries, there is increased risk of retained placenta. With stillbirth, maternal age more than 30 years, with uterine abnormalities, defective placentation, envelomatous placental incision, and previous history of retained placenta also plays a very important role.
So yeah, you're right. So when there is an over-distended uterus, when there is a multiple pregnancy, when there is also conditions where there is a suspected atony like polyhydramnios, we suspect sometimes mostly a retained placenta. So Dr. Maradha, madam, can you tell me how you will differentiate a trapped placenta? Because all you were telling about trapped placenta and retained, non-separated retained placenta. Is there anything when you're coming and looking at this patient that she hasn't expelled the placenta? So you want to know whether she has a trapped placenta or a separated, non-separated placenta.
All the signs of placental separation.
Yeah.
All the signs of placental separations will be there. Lengthening of the cord, fresh bleed, and if you can palpate through the edge of the placenta is palpable through the small narrow cervical os. The whole bunch of placenta can be felt. This is trapped placenta. When there is no features of separation like in adherent placenta and accreta and all, you should have an ultrasound to differentiate between both of them. And the hallmark of placental separation is absence of blood flow at the basal placenta and the myometrium when you do an ultrasound. And everywhere the myometrium.
What else you will see in the ultrasound, madam?
The myometrium will be thickened in all areas except where the placenta is attached, where it is very thin or even invisible.
Yeah, you're right. So that is what all the ultrasound picture and features of the retained placenta looks like. And there are, in another publication, what they have found out is the grayscale and the colored Doppler sonography in the third stage of labor for the early detection of failed placenta separation. They have found out there is no major difference on sonography between the contraction and the detachment phase. and there is a cessation of blood flow between the basal placenta and the myometrium following the delivery of the baby is the sonographic hallmark of the normal placental separation. A persistent blood flow demonstrated by the color Doppler sonography is suggestive of placenta accreta. So these are the two very important facts that you should see in a color Doppler when you're coming across a non-separated retained placenta. So that is very important, as rightly pointed out by our panelists. The Doppler and the ultrasound that's a very diagnostic point that you should keep in mind. So may I ask Shanti madam, when you will intervene? So now we are seeing this patient. She's around 20-25 minutes. You have seen her, checked her, and you are still in a confusion of whether she has a retained placenta or a non-separated placenta. But you want to do something. What you are planning and how you will be, what are the things that you will do to plan her expulsion? Or when you will intervene into her. You said that you can wait up to even 90 minutes, 60 minutes, but when you will intervene to this patient?
If she is bleeding profusely, even before that 30 minutes, if she is bleeding profusely and she is becoming hemodynamically unstable, I'll intervene even before 30 minutes, madam.
Yeah.
And if she is hemodynamically stable, I'll wait for, if it's a normal labor natural third trimester delivery, I'll wait for 30 minutes. Especially in a case of second trimester abortion, second trimester deliveries or induced abortions and like that, in situation, if the baby is delivered and in IUD also. In IUD also, the baby will be delivered, but the placenta cannot be, it may not be expelled. In that situation, so you can wait even for an hour with some ongoing medical management.
Okay, so will you keep anything in mind and you will be planning certain things when she's not?
I'll always arrange for blood and I'll just, I'll make the blood bank alert for the blood transfusion. Because anytime she may bleed, we are thinking that she's not bleeding. Slow trickle sometimes may cause a hemodynamic instability. So I always reserve blood for the patient. And I'll always plan for the theatre to be ready and plan for a manual removal of placenta if it is not coming out after this stipulated time.
So I agree with you. So you will be keeping planning about the blood, the anesthesia, the anesthetist, the theatre, and all your team to get ready. So can Madam Manonmani, madam, can you outline what are all the stages that you will be planning for her? How you will be planning for her, whether to do a removal or a traction or an anesthesia, or what you will have in your mind when you have just outlined how you will be managing her, the basic outline of the treatment.
Yeah. After delivery, after following Amstel, the placenta is not separated. First and foremost, you have to go. Then Amstel, you have got a control contraction. As well, you have to catheterize, and you have to plan for start 2 IV lines, green or gray in the above diaphragm, not in the lower limbs. And then you have to make the theatre ready and call the anesthetist and call for help. And bladder should be emptied. And again, you have to go and see whether it has got separated. In the meantime, you have to start them on oxytocins. So we will be expecting PPH. So oxytocin should be there. And in the meanwhile, again, we can go for a control contraction or can plan for manual removal of placenta and the theatre. If it is going to be second trimester partial expulsion, even you can go for the instrumentation. And you have to think all the complications following the delivery.
Yeah, yes, you rightly pointed out that these are all the things that we should
when the
keep in
patient
mind.
is having a scar in the uterus and the placenta is not coming out, we have to always think about the reduced complication of hysterectomy.
Yeah. So that is always there. Even when you're seeing a patient antenatally with a scar, you will be always seeing an ultrasound and you'll be seeing if there is a placenta accreta or anything. There will be always an evidence, even well planned before the delivery. So when it is totally not planned, like a clean case, there comes the real trouble for you. So now we have decided to go ahead to manage her because she hasn't expelled it till now. And we are very clear that she has a retained placenta. So how you're going to manage her as a first step of management? Can Rashmi, can you let me know how you're going to manage her initially?
If cervix is contracting, preventing placenta to expel, administration of nitroglycerin will help to relax the uterus and probably facilitate placental delivery.
Have you ever given
no, we have not given it, but probably the anesthetist, with the help of anesthetist, we do it. 400 micro, but we have never used sprays and all that, madam. We have not used 400 micrograms to sprays of glycerol nitrate can be given, or 50 microgram maximum up to 200 microgram can be given IV, or sublingual tablets can be given.
Okay, so now her uterus is relaxing well and you are removing the placenta. How you will remove the placenta? Will you go for any special precautions when you do removal, or is there any other thing?
You have to go for a control. You have to go for a controlled contraction, or gentle controlled contraction. Uterus is held up and placed, pushed up gently, and the umbilical cord is pulled down through steadily. A controlled contraction can be tried.
So, can anybody tell me about the umbilical, oxytocin injection, umbilical vein oxytocin? Have you got any experience, and is there any other important aspects? Can you let me know? Anyone?
Actually, there is no studies which say that there is any advantage of this umbilical vein oxytocin injection over the normal oxytocin which we give. So it doesn't actually have any positive.
So there are two different studies. One says that there is a positive improvement in the expulsion rate, or the time taken for the expulsion is less when you give a umbilical IV oxytocin. There are some studies which states, but some ultimately a systematic review said there is no other advantage. But still, when she's not expelling, you can try a intra-umbilical oxytocin injection, which may help in an expulsion before you go for a controlled cord traction. So, can anybody? Can anyone tell me about the controlled cord traction? How you do it?
Yes, ma'am. Like the hand will be on the non-dominant hand will be on the abdomen, and it will push the uterus up. And in the controlled contraction, we have to pull the placenta down with the umbilical cord. We have to pull the placenta down in the shape of the pelvic cavity. So, like in order to prevent inversion of the uterus, that is done. That's the Brand Andrew maneuver.
Fine. So if you are not able to do with a hand, will you use anything else?
Forceps.
And
forceps.
Because it will slip water and jelly.
Yeah. So sometimes it may, as rightly pointed out, it can slip. So sometimes we may need a forceps to hold it properly. When your other hand is just pushing up the fundus to prevent the inversion, you can use a forceps to slowly remove the placenta. So that is what the position, how you have to keep your free hand, and the controlled contraction has to be done with a Brand Andrew technique. So if madam is doing, Aarti is doing the controlled contraction, but she failed. What we are going to do next? Can anyone let me know? Radha madam, can you tell me what will you do if she fails the controlled traction?
We will go in for manual removal of placenta.
Yes, how you will do it? Can you tell me how you prepare her, how you keep her ready, and how best we will do this?
I will shift her into the theater
consent.
Yes, I will take consent that before shifting, and as soon as he is anesthetized, I insert my hand like Brand Andrew, but I'll insert my hand in between the placenta and the uterine wall gently, facing anteriorly. And
so what is the type of anesthesia you will ask the anesthetist to give, madam, at this stage?
IV, he will midazolam and all they have tried, madam. Short GA. Okay, short GA.
Yeah, short GA, especially you can use a halothane or an ether, which will relax the uterus much better for your manual removal to be comfortable. Otherwise, she may have a pain shock. You may not be able to go into the plane of cleavage. So you can ask them for a halothane, which may be giving a good relaxation for the easy manual removal. So that is how they do it. That is the procedure that you have to, how to introduce the hands along the layers and then go above, and then with the other hand stabilize the fundus and just go below the layers, separate it and catch hold of the placenta like a ball, and then you remove it gently. Make sure that the fundus won't come along with that. Remove every part of the placenta and then you remove that as a whole. So now we have Radha madam has removed the placenta nicely after the by the manual removal.
And,
After the procedure, will you leave the patient like that, or
no,
how
I
you
will
monitor?
I will keep her on an oxytocin drip 100%.
Yes,
I'll
yes.
just keep her uterus contracted only. And
Yeah.
so many times I've given misoprostol repeat dose also rectally.
Yeah.
And I'll observe the woman closely until the effect of IV has gone and monitor the vital signs. Every 15 minutes actually I do it, and every 30 minutes for 6 hours, and palpate the fundus to make sure it is contracted. In fact, I'll keep one attendant next and say, keep amma in the kai inge vechittu massage pannite, I will tell. And
so the one important point we should remember is the fundus. We have to mark the fundus, keep the fundus even for the assistants to note it down whether it is increasing the size or not. We can keep a fundus marking over the abdomen so that we can be very sure that the fundus is well contracted and well maintained.
Yes.
So now after the procedure, we have removed the placenta. We made sure that we are giving her most of the oxytocin. We have given the misoprostol rectally, everything you have given, but still she's now trickling. Now also she's trickling. So Madam Shanti Madam, what is your opinion on this patient? Still she's bleeding and she's trickling. What is in your mind then?
Usually in case of a manual removal of placenta, because atonicity is the commonest cause for this retained placenta, so surely we'll expect an atonic PPH. So my technique is that after even removing the placenta from the uterus, I'll just push the placenta downwards. I'll never keep my hands out of the uterus. I'll hold my whole of the fist in the uterus, and I'll keep the other hand on the abdomen, and I'll ask the people to give prostaglandin and all, because otherwise that uterus sometimes may get inverted when the atonicity, so that uterus may get inverted. Until the uterus contracts well and when there is no bleeding only, I will take off my head from the uterus. When the uterus is gripping your hand like that, then only. That is the time-old practice I am practicing for so many years, so that I don't have much bleeding usually due to atonicity. But if it is continuously trickling, after this removal of placenta, always you suspect some part of the placenta would have been left inside. Immediately we'll do an ultrasound by the side, and if you see that placental bit is very small thing, then I just leave the thing and I'll give the misoprostol rectally and I'll come off. Usually I won't do much after that.
Yeah.
Otherwise, you can give blood products and you can stabilize the patient.
So as rightly pointed out, we have to suspect an atonicity. So always keep in mind, and even a small fundal dimpling or a inversion in that point also can cause some amount of a shock and bleeding, and some retained products could be the reason, and sometimes some lacerations which has happened in the cervix or in the vagina or in the uterine lower segment can cause all the type of a laceration, also can cause bleeding. So you have to be very clear, check a scan for retained products, see the uterine contractility, and also visualize the whole cervix and the vagina for any lacerations also, which may be the cause for the bleeding. And of course, when you have a retained products, will you do a curating? Whether you will advise routine curating to avoid this?
No routine curating,
madam.
Never.
Yeah.
So we'll not do routine curating, because definitely we'll end up with the perforation. So we'll never do. Routine curating is not at all recommended.
If at all, if you suspect with an ultrasound guidance, you can do if you feel that there is a retained product, always do a curating with an ultrasound monitoring. That will help you to have an exact point of the adherence to be removed. That is one important thing that you should keep in mind. Yeah.
I want to add one point, madam.
Yeah.
Nowadays, carbitocin, the anesthetist is giving with the fluid very nicely for all these cases. So chances of trickling, PPH and all have drastically decreased. Carbitocin is really very helpful.
That's good. Yeah, you're right. So I think.
Sorry to interrupt, Dr. Jairani.
Yeah, ma'am, we are completing. The complications, we are completing.
Yeah.
So I think
actually the panel is so nice. We want to continue it, but time constraint. That's why only.
Yeah. So When you will, Rashmi, can you tell me when you will advise an obstetric hysterectomy?
Madam, if medical management has failed, then probably you have to go for a obstetric hysterectomy, or if you suspect any adherent placenta, then you have to go for obstetric. Madam, I would like to add something else. What about the role of balloon tamponade and all that for management of?
So if there is an atonicity, definitely you have to manage as a PPH. When there is an atonic PPH, when after the expulsion, if you have an atonicity, you have to manage her as a PPH of the atonicity. That is a different one. So if she has a retained placenta, you have to remove her retained placenta. So these are causes. Once you remove the placenta, you have to look into all these things when you're planning for the next step. So to conclude, Varsha, I'm happy that you will be very happy that I'm finishing. So retained placenta can be defined as a lack
the panel was so nice.
Yeah, so you can wait up to even 90 minutes and 120 minutes, but you have to keep an vigilance to keep everything ready for the removal and monitor the vital signs of separation and bleeding and all the other complications which she go through. So with this, all the concept in mind, we can plan a very good third stage of labor, and the retained placenta can be prevented if you do the AMSTIL properly. That is the main thing, that you should do the controlled contraction and also proper removal of the placenta with a good care. That is always the important point, that you should do whatever the patient may have. So this is a very important point that we have to keep in mind. Thank you, Varsha, and thank you all my panelists who are all very good teachers who have given a very good explanations for each and every aspect of this retained placenta. Thank you, madam. Thank you,
Jayarani ma'am, Varsha ma'am.
Yeah,
thank you,
You are
Dr.
so
for this
academically
Thank
also
you,
and
Ramila.
socially also, and as a president of Oxy, you are such a brilliant person, so accommodative, so friendly, and so academically strong. Also, I could feel Manon Mani, everybody is so academically oriented. Really, you have kept the standards very high from the very beginning, and I am really thankful to all of you to be involved here. And our chief guest, Dr. Vijay Lakshmi Sheshadri, she is there till end. So I am really thankful to the guest of honor, both the guest of honor and the chief guest being here, and all the OGCC and Tamil Nadu societies being present here. And we had almost 450 registrations and live on this Zoom. They were 209, we can see, and YouTube also many join on APL. So thank you so much for this elaborate, very nice, high standard academia, and all the chairpersons. I'm thankful to you and all the panelists, esteemed panelists. You really gave deliberations individually, and I'm really thankful for your active involvement and keeping so much of your, giving so much of your time and attention for this exclusive webinar. Thank you so much.
Thank you, Varsha.
Thank you,
Thank you so much. Thank you, madam.